Hi everyone, my name is Priyesh and I'm currently QUESMED's Digital Teaching Fellow. Today I'm going to give you a quick tour on how to get the most out of our platform. So once you've bought a subscription and you've entered the QBank platform, the easiest way to start doing a set of unseen questions is hitting our Quick Start button. Then you'll see that for each question we have detailed explanations on why each answer is correct or incorrect, and we also have a page associated with each question. This goes into depth on everything that you need to know for that condition. Next, I'd like to show you our flashcards, and these are based on an AI algorithm which takes into account the questions that you've got wrong and need to learn further, to produce a daily set of flashcards which you can then rate to then further help determine what you need to see on the next day. And as I mentioned, these refresh every single day. We have mock tests on our platform as well, including prescribing assessments. And as mentioned, we have a detailed knowledge library, which is a textbook covering exactly what you need to know for your exam for each condition. For example, acute coronary syndrome, where we have a summary followed by all the important aspects of the condition, including references at the end. We also have videos which cover tutorials as well as lectures. And just to quickly show you, we also have an OSCE which will cover the practical elements of your exams, including A to E assessments, communication skills, examination stations, and history taking stations. So for example, with each and every station, we can take them under timed conditions, and this is something that you can do with your friends where you can each take up a role and you can practice and go through them together. And for each OSCE station, we also have a walkthrough on how to approach that station as well. So that's everything that I wanted to cover today. That was a whistle-stop tour. If you have any other questions, please email us at info@quesmed.com, and I hope you found that useful. Thank you for watching.
Hi everyone, my name's Georgia and I'm part of MOGIG for 2024, and welcome to our fifth and final lecture in this lecture series covering common presentations to ONG presentations that you're probably going to encounter in your fourth year rotations. So this lecture, along with all of the other lectures in this series, are proudly supported by QUESMED. As you can see, this lecture will be covering routine early pregnancy screening, infections in pregnancy, and pelvic organ prolapse. We now just have a quick message to play to you on behalf of QUESMED. So the matrix items covered by today's lecture will be routine antenatal screening in early pregnancy, torch infections, and pelvic organ prolapse. All of these topics are particularly important to know for your ONG exams and also for your clinical practice, but I'd pay particular note to the torch infections, as these are also covered in your paediatric matrix as well. And just a disclaimer that the lectures we do create are only created by students for students and may be inaccurate or incorrect, especially as they become less recent. We do try to keep them as accurate as possible, but please know that we do make mistakes, and please let us know if you do identify any. So the first case we're looking at today is the case of Eloise, who's a 32-year-old female. She presents to your GP clinic and informs you that she is pregnant. She believes she's approximately 5 weeks along based on her last menstrual period, and they are usually regular and occurred every 28 days. Up until now, Eloise has no medical history of note, takes no regular medications, and doesn't take any vitamins. She said this was a planned pregnancy with her husband of 4 years, Philip. She's only confirmed her pregnancy with a urinary pregnancy test and is after a more official test from you. She drinks 2 glasses of wine on the weekend and does not smoke or use any recreational drugs. She asks you what you would suggest we do next. So have a think about what types of things we want to do in a patient who presents to us and who is pregnant. What things might we want to look for and screen for? So after some thinking, you recommend that Eloise start taking some folic acid every day to prevent neural tube defects, and you also counsel her on diet during pregnancy, including that she probably shouldn't be having any more alcohol. You send Eloise away for the following routine tests, all of which she provides consent for. So you send off your FBE, your quantitative beta-HCG, HIV serology, hepatitis B and C serology. You screen her for her blood group and any antibodies. You look at her rubella serology, her varicella zoster serology, and her syphilis serology. You also obtain a first pass and midstream urine sample from Eloise, and you send this off to look at any asymptomatic bacteria and look for any STIs such as gonorrhea, chlamydia, etc. So you catch up with Eloise 2 weeks later with her results. She says she's progressing well in her pregnancy, but she's beginning to feel a little bit of mild morning sickness, but otherwise is pretty happy. Her results are as follows. Her FBA appears normal. She has a positive quantitative beta-HCG, which is appropriate for the estimated gestational age. Her HIV serology becomes back negative, and her Hep B C serology comes back as evidence of immunisation against hepatitis B, but no evidence of previous or current infection. She is blood group O positive and no antibodies are detected. Her rubella serology demonstrates evidence of previous immunisation, and those have an appropriate titer level. And she also has evidence of prior infection with varicella zoster. Her syphilis serology comes back negative, and in her first pass and MSU samples, we identify E. coli, which is pan-sensitive. So what things might you suggest to Eloise now? In terms of management, we know that Eloise's immunisation status is up to date for rubella, hepatitis B and varicella, so she probably doesn't require any further boosters or precautions at this stage. You advise Eloise, though, that she would benefit from an ADT immunisation at 32 weeks, as is suggested for all pregnancy patients, and she is happy to go ahead with that. You advise her she won't require any anti-D injections as she has a positive blood group, and she's very happy about that. You also tell her that she's tested negative for hepatitis B and C, HIV and syphilis, that no further action is required, and that her immunisation for hepatitis is up to date. You also identify that she had asymptomatic bacteria and tell her that because she is pregnant, she will need treatment with nitrofurantoin, and you give her a script for this. You also tell her that you'll need to repeat her urine sample 1 or 2 weeks after the completion of her antibiotics, just to ensure that the infection has cleared up. Have a think about why we might want to treat asymptomatic bacteria. Would we normally treat it? Usually, we only treat asymptomatic bacteria if patients are pregnant due to the risk that that infection could spread into the placenta or fetus. You rotate onto your O&G rotation and are then surprised to see Eloise again at 25 weeks in the antenatal clinic. Eloise is happy to see a familiar face, but she's a bit worried because apparently some results came back abnormal from her 20-week morphology scan. You have a look at Eloise's 20-week morphology scan report and find that all of her fetal biometry is within the 75th centile, and that her estimated fetal weight is on the 70th centile, so there's no concerns in relation to growth. However, on her placenta, you notice granulomas that are noted. Her placenta otherwise is in an appropriate position, and there's no concerns about abnormal placentation or malpositioning. You also have a look at the anatomy or morphology report for the fetus, which shows overall normal growth and development for gestational age. However, the report also did notice that there seemed to be some intracranial calcifications and some mild grade hydrocephalus. So what are your differentials? There's probably one acronym that should spring to mind as you're thinking about those things, and that's TORCH. So TORCH infections refer to a series of infections which can cause pretty significant congenital malformations, including toxoplasmosis, other, which consists of syphilis, HIV, parvovirus B19, varicella, rubella, CMV, and HSV. The reason we worry about all of these particular infections is these can have significant developmental implications for the fetus and can also lead to life-altering consequences. So there's quite a bit of information to know for each of the TORCH conditions. However, I like to kind of split it up into thinking about what the infection or agent is, if there's any particular risk factors associated with each condition, and what the signs and symptoms are for the maternal, but also the fetal aspects of things. It's also important just to know a little bit about management and the fact that certain findings during antenatal care may be more indicative of one syndrome or condition over another. So looking through these conditions, we can see here that toxoplasmosis has instances of hydrocephalus and intracranial calcifications. The only other one here that we might be concerned about is potentially varicella, which also leads to hydrocephalus. The other one that we are probably concerned about here is CMV, which can lead to periventricular intracranial calcifications, so slightly different to what we've seen on the report, but no hydrocephalus. So the differentials we're thinking about then are toxoplasmosis, varicella, and CMV for the findings of hydrocephalus and intracranial calcifications. However, we know based off the history of Eloise that she's unlikely to have an acute varicella infection because she's got that prior immunity. In terms of the investigations and management from here, you talk to Eloise and tell her that you will check with your supervisor, but that you think that what might be going on might be related to a congenital infection. The ones that you're particularly worried about are toxoplasmosis and CMV, which in you or I doesn't cause significant illness or morbidity or mortality, but can have effects on the unborn fetus. So you tell Eloise there's a couple of tests you want to run to confirm whether either of these conditions could be contributing to the effects on the fetus. You tell her that for both of these, you're going to do an amniocentesis, so pass a needle into her belly and sample a little bit of fluid, and then also undertake a PCR of that fluid to see if toxoplasmosis or CMV are present. You refer Eloise off for her amniocentesis, and the results come back as follows. They detect toxoplasmosis, but not CMV. What should we advise Eloise from here? So you tell Eloise that she is infected with toxoplasmosis. You advise her to commence pyrimidine and sulfadioxone with folic acid supplementation because both of those agents can reduce folic acid availability, and you want to protect her against neural tube defects. You also tell her that she's in the 3rd trimester of her pregnancy, therefore there's a low risk that the infection will significantly impact the health and development of her unborn baby. You also tell her that she'll probably need continuing monitoring a little bit more closely than normal, just to make sure the baby is continuing to grow and develop well until after birth, and that the baby may need some tests or a special care nursery or NICU admission after birth as a precaution. The next case we have today is Violet, who's a 60-year-old female. She presents to you due to concerns of a lump down below. Violet otherwise has a pretty unremarkable past history besides hypertension and hypercholesterolemia, which she just manages with perindopril and atorvastatin. Otherwise, Violet's pretty healthy and enjoys running. She is a non-smoker and enjoys the occasional glass of champagne at a soiree in the Ton. What questions might we want to ask Violet on history? So it's important when you're taking any history to start off with the WWQQAA, like we all know and love, as this will include you into what potential differentials you could potentially be dealing with here. The main thing you want to know about the lump is where is it, and does Violet know what it looks like? For pelvic organ prolapse, we want to know if the lump is there all the time or some of the time, as if there's a particular pattern or any triggers that lead to the appearance of the lump, that may commonly indicate a pelvic organ prolapse. It's really interesting, but patients actually do describe pelvic organ prolapse as a lump, even though we know that it's sort of more of a bulging of material out of the vagina and vulva. So just be aware when someone says they are presenting with a lump, it may be pelvic organ prolapse. Patients also commonly experience a dragging feeling, so it's important to ask them, this sounds a little bit strange, but do you experience any dragging sensation? The other thing which is important to ask about in prolapse is if there's any fecal or urinary incontinence. In these instances, it can indicate that part of the bladder, known as a cystocele might be moving into and prolapsing down into the vagina, or for fecal incontinence, it might be a component of the intestine that's prolapsing into the vagina. We also see commonly with prolapse that exercise, bearing down, sneezing, coughing can exacerbate or make the lump feel bigger. The next thing you want to be aware of is any malignancy, particularly vulval or vaginal carcinoma. So of course, we want to ask the usual symptoms about weight loss, night sweats, and fatigue. The other things that we might want to ask about is any bleeding or discharge from the site, whether her CST is up to date, and if she's ever been a smoker. As infection with HPV 16 and 18 and smoking status can be an increased risk factor for both vulval and vaginal carcinoma. The last thing we want to think about is any vulval or vaginal cysts, in which case these are usually painful and may have some discharge associated with them. So Violet tells you after you ask all these questions that she's only noticed the lump in the last year since she took up running. She said that the lump isn't there all the time, but mostly comes on after she's returned home from her run. The lump is inside the opening of her vagina, and it's almost like something is coming through. She says that her lump isn't painful, but rather uncomfortable, and she reports a dragging sensation. She hasn't experienced any instances of incontinence or urinal feces. She also says that she hasn't had any B symptoms, hasn't noticed any pain, itching at the site, or bleeding or discharge from the site. She's a non-smoker and has never smoked, and her CST has otherwise been up to date with no concerns. So what parts of the history might be important to ask Violet based off what we've got so far? We might be thinking about things like whether or not she's had lots of children before, and whether or not she has done things like pelvic floor exercises during her pregnancy. We also might want to ask whether or not she's had any issues with incontinence before, and whether or not she's had any particular gynecological interventions on her vagina or pelvic floor, such as tearing during pregnancy, instrumental birth or delivery, previous vaginal reconstructions, things like that. So what is our diagnosis based off Violet's history, and what should we do next? From what Violet's told us, it sounds like she's got a history that's very consistent with pelvic organ prolapse. Therefore, we should manage it as if this is pelvic organ prolapse and examine her to make sure that this is the case. So the provisional diagnosis is pelvic organ prolapse, or POP. So you tell Violet that you'll need to do a speculum examination and obtain consent, which she is happy to provide. On examination, you initially notice no prolapse in the vaginal canal. You then ask Violet to bear down and notice a small bulge of tissue descending from the top of the vagina down towards the vulva. On further examination, using the half of the speculum to retract the anterior and posterior walls of the vagina, you notice that this is a grade 2 uterovaginal prolapse. So part of the uterus from up high in the apex of the vagina is moving down into the vaginal canal. So you explain this diagnosis to Violet, and she asks you, why has this happened to her? So what risk factors does Violet have that make her a higher risk for prolapse? She is significantly at risk for prolapse based on her history of 8 previous pregnancies and birth, all which were normal vaginal delivery. This put significant strain on her pelvic floor and has probably led to a large component to why she's experienced prolapse now. She's also over 40 and is postmenopausal, which are both risk factors for prolapse. And she has regular straining during running. So it's likely since she started running, she's had a little bit more pressure on her pelvic floor, and that's made this prolapse become more noticeable and more significant for her. So Violet's disappointed with this diagnosis and wants to know how to manage it. She just doesn't want it to affect her running. She's really enjoying it, and it's a good way to wind down from worrying about her children. What advice would you give her? For prolapse, it's really important to split up management into lifestyle, pharmacological, and surgical intervention. To start off with, it's really important that we think about our SNAP-W interventions. Maintaining a healthy weight will try and keep any extra pressure off of her pelvic floor and make it more manageable for her. We say that she should still keep running as tolerated and ensure that she maintains a healthy diet. We also encourage her that she should avoid straining where possible. So she should make sure that she's opening her bowels regularly and using laxatives if she's finding that they're difficult to pass. We also tell her she should avoid lifting heavy objects as this can put strain on her pelvic floor, and that she might benefit from getting her sons to help her out with anything like that. We also tell her that it's important to maintain a good alcohol intake that is no more than 1 to 2 drinks in a sitting. The next thing we're going to do is refer Violet to a pelvic floor physiotherapist for some strengthening exercises, which she's happy to do. And we're telling her that we're going to trial a pessary, which is a little rubber, I guess, donut-like shape. Some of the shapes and sizes do vary, which helps keep her pelvic floor and her uterus up in the apex of her vagina and stops it coming down. You tell her that you'll also give her some topical estrogen cream to help with this, just because she is postmenopausal, which means that sometimes the tissues in the vagina can get a little bit dried out when a pessary is in, just to prevent any sores and things like that. We also suggest that Violet might consider surgical management if she's still having issues, if the pessary and pelvic floor physio don't really help her with her symptoms. So thank you so much for joining us for our final lecture in this series. Once again, we are proudly sponsored by QUESMED. We wish you all the very best for your exams and for your clinical placement. And please feel free to check out our other resources, including Apex and Matrix summary sheets that are on our Google Drive. Thank you very much.